Good, got it. Let's click that. Thank you, Karan. Uta, you had one remaining question. You asked in the group, do you use the word disjunction as a synonym, probably you meant, of the word dissociative or dissociation? You remember that, Uta? You asked it? Your mic is off. You can switch it on.
Okay, I remember, yes.
Yes, I would say disjunction is a term that, as you know, stems from logic. It has a particular meaning in logic, meaning that two parts are either totally separate from each other, they stand in a disjunctive relationship, but they can also have overlap.
Okay.
And that's an interesting feature, I find, because that is typical for most dissociative agents. They have something in common and they have their own domains. And this allows us, I'm starting, we, a logician and I,
yes.
We have the ambition to see if we can formulate the theory in terms of logic. I do not know if we will ever achieve that, but we're working on that. And through that means I got in touch with the concept of disjunction. And I said, yeah, that fits. Because then you can put that in terms of logic, and you can also put it in terms of graphs.
Okay.
So that's it. In order to actually fight the idea that dissociation is splitting, that parts are split. They are not split, they are divided.
Divided.
Divided. And you could say this in terms of logic, they stand in a disjunctive relationship. And that's why in that formula that I used in the last video, that is also in the chapter that you have, I used that disjunctive side. Because in that sense, it is the same. But of course, in a psychological sense, it's not the same because dissociation entails a particular understanding of dissociation, the framework of dissociation. Good.
Thank you.
Yes, you're very welcome. Irena Anotsklar had a clinical question, but she's not there. I'm hesitating a bit whether I should address it or not. Perhaps I'd better first ask if you have any theoretical, scientific, or clinical issues regarding dissociation that you would like to discuss. Anything you're struggling with, conceptually, clinically? Yes, Uta.
Yeah, I have a question about dreams. When a person dream, a normal dream, it's my question is, who dreams when I am asleep? And who is dreaming when I am asleep?
Yes.
And what's the difference between nightmares? I think an agent will bring the nightmare, and between normal dreams and nightmares.
Okay.
Okay.
Yes. Two questions, right? And then when there is a dream going on, a phenomenon, is it still the organism that brings forth the dreaming phenomenal self, or the phenomenal self as it appears in the dream? that's in the dream,
Mm.
becomes part of waking consciousness. So that, let's say, the waking phenomenal self, in as much as the waking phenomenal self integrates the dreaming direction. Not necessarily, we can have nightmares that are not directly associated with traumatic experiences, but been in a traumatizing event, and one was very scared. You may, in a sort of twisted, weird way, re-experience or bring forth feeling very, very scared. Not necessarily in a direct content-wise connection with the actual event.
Mm.
We may also have a sort of nightmare in the form of a worse dreaming, actually as an A&P, as it appeared, of a little girl drowning in a moor. Well, that was an allegory, an extended metaphor, where the little girl in the dream was actually an EP, fragile. And she was not really dirty, although in the dream she was dirty, but she felt dirty after sexual abuse by her father. And she was drowning and screaming for help, which was a metaphor, rather straightforward metaphor, for A&P, you must save me out of this moor. Okay. And A&P in the dream was the one who was walking on a path with moors to the left and moors to the right. And first she did not notice the girl. And then all of a sudden she noticed the girl. There was the perception. First there was a zero-person perspective with regards to the EPF. Then there was a third person. There is someone in the moor. What's that? Well, then it was a girl with a white gown that had become dirty. And there it started to flow and become ever more second person. And in the end, the feeling, this is about me. And in the end, even as we reapproached the dream and continued to dream in the next therapeutic session, and it was sort of clear to her why she had been for basically all her life severely depersonalized.
Super.
Because it was a nightmare, but also a very creative act on behalf of the whole organism to present the problem in this way.
Yes.
And there was a lot of unconscious constitution involved, because she never thought of it in those terms, not as the A&P, but also probably not as the EP. I had never met the EP. I didn't know there was an EP. I suspected something of this nature, but I got, as I said previously, nowhere with this patient. I tried everything. Depersonalization as a single, strongly developed symptom is very hard to treat. I've not always been successful in helping the patient overcome severe depersonalization. But in this case, in the end, it worked. And I made a mistake. I said in the previous hour, it was after 2 years. I thought, oh, that was not right. It was after 4 or 5 years. It was much, much longer. I was struggling with her and she was struggling with herself. But in the end, we got there.
And also very interesting with the A&P, he ignores the EP, no? Like.
Yes, every element.
Every element. Yes.
In allegoric terms. Yes.
Super, yeah, sure.
Yes, I was very impressed with that. And speaking clinically, dreams can often be used in a sort of creative fashion.
Yes.
What I've done more than once is when the dream suddenly stops, when the dream becomes, the nightmare becomes too scared and the patient wakes up in the scream.
Yes, yes, like this.
Which is the sort of habitual pattern. Then in as much as the patient is inclined to do that, is willing to do that, step back in the dream in the session. Imagine you're back in the dream. I've done that with the patient Paula, which is also
Paula, yeah.
in the Blue Book, in the Trinity.
Yes.
Same thing. And I could give many other examples.
Yes.
And generally, when the patient really is willing, really getting into it, it can be very productive.
Yes.
Yes. The interesting thing is you don't need to do any dream interpretation.
Yes.
You don't need to go about it as some psychoanalysts might be tempted to do it.
You have to go the path of the dream. Like
Yes,
this.
yes. That's what I tend to do.
Yes.
It also sometimes works the other way around. You can sometimes invite the patient to have particular dreams. Let me also, if you're interested, I give you an example of that. There was a young woman who had a job, who was proficient at her job. She did it well until there was a friend and she had a car crash. And it was not very serious. The friend came out all right. She felt good. But from that point onward, my patient couldn't sleep anymore. She had a massive phobia of falling asleep. Why was that? That was related to the fact that she was dreaming about a monster. For some reason, there was a monster chasing her in her dreams, time and again. And this condition, her condition became serious because she didn't sleep anymore. She lost her job. She was totally depressed. She was rather obstinate. She didn't want to be with me in the first place. She had a kind of hate that she had to be in therapy. She didn't want it, but it became urgent because it was not only that she had the nightmare, but then when the monster almost got her, she woke up in a scream, rushed out of bed, went into the living room, and sometimes even in the street. But she had no control over that. It happened. Thus, speaking in our terms as the A&P, she found herself sometimes back in the street and even naked because she used to sleep naked. And that was, of course, very humiliating. It never went into any severe accident. Nobody ever saw her, probably. But that was the situation. And good, what would you do? She was not interested in examining herself. She's sitting there reluctantly, really pretty irritated. You know, those eyes, sort of, must I be here? I don't want to, procrastinating and all.
Yes.
Good. Now, what to do? I thought the best we can do is to step into her dream. It went sort of like this. There's a monster chasing you. Yes, I already told you. Yes, I got that. And that sort of interaction. And he's chasing you. That monster must be very, very powerful. Yes, I'm totally scared. And a little bit more of that. And I said, well, there is a thing that puzzles me. If the monster is extremely powerful and actually is out there to get you, and has done so for actually 2 years now, then I don't understand why he has not grabbed you all along. Yes, she says, but when he comes, I run. The monster is awfully powerful, but you are fast enough to escape. And you say, it's a he. Are you sure it's a he? What does he look like? Well, she was a little bit like this. I don't know. Why don't you know? Well, I never saw him. It feels like that. you feel chased by something that you experience as monster-like, and it might be a monster. Good. Now, it went on a little bit more like this, a little bit more differentiation, but then I came to my intervention. I said, well, before I can decide if therapy would be needed and fruitful for you, there's one thing I need to know. What then? She said. I said, it's the following. I need to know what the monster actually wants from you. Because if he is really so powerful, he could run one step faster than you and grab you. He didn't do that. He doesn't come to me at night. He doesn't come to other people. He always comes to you. Thus, I'm curious, and you might as well be curious, why the monster
will
is
catch you
anyway. Thus, go back in the dream. You can be pretty certain that he will visit you again this night. And then you grab all courage that you have together, and you turn around, you point at the monster, and you say, my God, who are you? What do you want? She was a little bit like this, but she sort of took it.
It works.
And she went home. She came back. She was smiling. Okay. Before you tell me why you're in a good mood, tell me, what did the monster do? What did he tell you? Well, and she was a little shy about it and said, well, I turned around and there was no one there. Ah, what a weak monster. Now you find the courage to turn around. Now he backs off. What a weak guy, or whatever it was. Yeah, she says, I don't know, but I've been sleeping well. Totally separated from this, later in that hour, and she was more accessible, she spoke about being assertive with her chef at work and being assertive with her father. Really putting up some good boundaries, confronting them. I made sure that we never made a connection. But in this way, this person was helped. She went home, and I got later information from her GP, her physician, that the problem was over. She was back in work and she was living well. That was the whole therapy. So this is an example of how you can use a dream. And you can also do that when it's a traumatic memory. What would you need in your nightmare? And how can we develop that? And you practice that in the imagination.
Yes.
I'm not saying it always works. It's of course, as usual, context dependent. But yeah, these are some good applications.
That's nice. Nice.
Yeah.
Nice intervention. Thank you.
Yes. This is the general principle that you know from me in courses.
Yes.
Actually, the Ericksonian principle of utilization. Use what's there instead of trying to create what's not there yet.
Yes.
Generally, we have, as therapists, we're trained that way, and tendency to suppress symptoms. Or to find, in any case, ways of reducing symptoms. This is a different sort of approach.
Yes, of course.
Where you step into the patient's world and connect with the actions that they are already engaging in. Here, the patient running away from what she suspects is a monster. And proposing a new action. Good. It's a good principle once we get a feel for that, for utilization.
Yes.
Use what's there instead of creating what's not there yet. Good. Any other thing?
Thank you very much.
My pleasure, Uta. I posed some questions in connection with the third video. Can you relate symptoms to problems of synthesis, problems of personification, problems of presentification, problems of symbolization, problems of realization? That was my invitation for you.
Do you want the people to respond to that in voice or in the chat?
No, in voice. We are a smaller group.
My internet connection is unstable, so you won't see me, but...
Okay, that's fine. Yeah, you can speak and switch on your mics as you do that.
Am I allowed to ask my question in German because my English is not that perfect?
Are we all? I think we all speak German, don't we? We have.
Amelia, do you speak German? Okay. Your last name is not very Deutsch. Barragan.
Yes. Daniel, do you? Yeah, you're living in Germany, right, Daniel?
You must be on another call.
Yes, I guess. Ja, also das geht gut, glaube ich.
Ich habe eine Frage wegen der Präsentifikation.
Ja.
Die Frage war ja, welches Verlangen könnte das versuchen zu verhindern, oder? Diese Präsentifikation. Habe ich diese Frage richtig verstanden? Und da war ich mir unsicher mit der Antwort. Ute hat mir dann ein bisschen geholfen mit ihrem Kommentar, aber so ganz deutlich ist es mir noch nicht, welches Verlangen dahinter steht, diesen Mangel an Präsentifikation.
Ja.
Vielleicht kannst du da noch helfen.
Ja, gerne. Lass uns das zusammen versuchen. Lass uns sagen, wir haben eine einfache disjunktive Struktur. Ein ANP und ein EPF. Und lass die Dynamik so sein, dass ANP motiviert ist, verlangt, die Welt, die Erfahrung der EP nicht zu integrieren.
Mhm.
EPF integrieren heißt, die Erfahrungen teilen mit EPF, sodass ANP fühlt, was EPF fühlt. Aber EPF auch anfängt zu fühlen, was ANP fühlt. Es geht in den beiden Richtungen. Und wenn die Gefühle sehr unangenehm sind, sehr peinlich sind, dann kann es so sein, dass ANP motiviert ist, um das zu vermeiden, mental zu vermeiden. Nein, das tue ich nicht. Und jedes Mal, sagen wir mal, wenn EPF auftaucht, reagiert ANP darauf mit sich selbst betäuben, mit Alkohol, Drogen, Selbstverletzung, Ablenkung oder mentale Vermeidung. Ich bin nicht gut dabei. Im extremsten Fall Bewusstseinsverlust. Ja.
Would you be able to at least recap the question in English and then answer in English, because this is the session for English.
Yeah, yes, you're fully right. Okay, I repeat for you, Maria. I start all over again. Your question is, I have not really grasped yet the link between a particular longing, a particular type of longing, and a lack of presentification. Well, generally it is like this. Let's say there is a simple structure of one ANP and one fragile EP. It could be a patient with post-traumatic stress disorder. There is one horrible thing that ANP fears to take to herself. If she is to take the fragile EP to herself, that would mean bringing something that happened in the past, that which is being reenacted by the fragile EP, to the present. So that what happened in the past becomes part of the experiential domain of the ANP as well. And if the ANP does that and manages to synthesize her real chronological phenomenon now, in our case, March 26, 2022, then that would be presentification. ANP synthesizes EPF's mental contents and behavioral contents, that which the EP is, so to speak, brings it to the present, but manages to have her phenomenon now, March 26, as being the most real. Yes, it happened, and now I'm here.
So it's a part of the personification?
It includes personification.
Okay. Mm.
But the first thing it includes is synthesis. ANP must feel
Yes.
what EPF feels. The pain, the horror, being dirty, the fear, the disgust, whatever it is that EPF reenacts. That must first of all be synthesized. As you get at the experiential level, a connection between ANP, a synthesis between ANP and EPF. Now, if there is lack of presentification, it may be that the ANP reenacts the traumatic incident together with EPF, loses her touch with 2022, and disappears in, let's say, 2010. She's back, let's say, when it was a car crash, she's back in the car.
Yeah.
But so the presentification would be a good news, or to realize that the accident is over.
Yes.
So why don't they take more effort to do this automatically?
Okay. Let this be, you are an ANP, if I
Okay.
may use you as an example. Let this be the experiential domain and the cognitive domain and the behavioral domain of an EPF. Now, this is dirty, this stinks, this is full of fear, full of anger and shame and disgust. Now, when you've lived the experience, and if you have not integrated that awful thing, what do you do as ANP when it comes to you in a nightmare? It floods you in a nightmare. Let me be you. And
Yeah, I try to escape or get
Right.
away. Yeah,
you try to escape. Now, imagine that it works, that you can escape from it. Then that is EPF abandoned. The one you were, let's say, during something horrible, does not become integrated in you as the one that you are now. It happens again, another nightmare. It comes again. You feel it coming and you avoid mentally, again and again. She feels abandoned by you because you're not there to help her. This is like little girl stuck in the moor. Okay, this phenomenal self world stands by itself more or less. Every time when it comes, you push it back. Okay, so now we have two agents, the one who reenacts, the EPF, and the one who does not want to take this aboard to herself. Here you have the dissociative structure. Now, if this happens more and more and more, even mentioning the thing may be enough for you to avoid. The avoidance may become ever stronger. And actually, mental avoidance after having lived something horrible is the best predictor for the development of a post-traumatic stress disorder. Good. Now, what needs to be done? Well, if you take it to yourself in a matter of 1 or 2 sessions, it's over. However, you don't know that. You are classically conditioned to avoid this. Why? If you touch it, it hurts. Thus you pull back. And this pulling back, this mental avoidance may become a conditioned reaction. And it may even work pre-consciously. Even if pre-consciously this comes up, and that may have been the consistent depersonalization in the patient that I've described this afternoon.
Mm.
I'm depersonalized. I don't know what's wrong. She lost all touch with, in her case, the raped little girl. Good. Now, what is needed here? We need to help A&P find the courage and the longing to integrate and to stay with it, as it is said in EMDR, or as I would say, to synthesize this as something horrible that happened to a little girl. That's the synthesis. I feel it. I experience it. Then comes the personification. I was that little girl. Then comes the presentification. It's not a thing of the present, it's actually a thing of the past. But before I can experience that it's a thing of the past, I must first
feel it. Yes.
I must first feel it. And that is the step that is typically not taken by the A&Ps.
As a first personification, and then probably be followed by the
synthesis, feel. Feel it, know it, perceive it, have the images, etc. All those elements. Then just feel, connect in total with, in this case, the little girl. And then next step after the synthesis is I was that little girl.
Yes.
And that is personification plus presentification. It's I, it's my phenomenal self, my phenomenal world, and presentification. It happened as I was a little girl. It's not a thing of the present.
Okay.
And that's a hard thing also at the relational level, because many patients tell us, I can't trust you. People are not to be trusted. Why do they experience that? Because they experience a whole lot of betrayal in their life. And they project it on us. You will also abandon me. You will also feel that I'm wrong, that I'm to blame, or you may lose interest in me, whatever. You will abandon me. And they repeat that at a relational level, also as A&P, and not seldom in disconnection with the EPFs that are actually the ones who carry the betrayal. But a little bit of that perspires to A&P, and A&P too feels, I should not engage with people. Or in reverse, people are basically good, I'm the trouble. Okay, yeah, so no, people are fine. At my work too, they like me, but I'm bad. Which could also be relational reenactment. You cannot really be interested in me because basically I'm dirty. You should not touch my hand because you will feel dirt. Or these ideas. They may be associated with the fragile EP or in some cases also with the A&P. Thus the reason that people do not integrate in our terms as A&P, the EPFs and their world, or for that matter, the EP control, is that it's hurting. And why is that? One more thing. This structure here, the EPF, has no presentification. The past is her present. Thus to her, it is not, I'm telling you something that happened to me 20 years ago. I am that experience. In that sense, a traumatic memory knows no time. We think, oh, it happened 20 years ago. Yes, we can do the presentification, but not the EP. Thus, when that fragile EP comes in touch with the A&P is drawn into the past. Bessel van der Kolk once referred to it as a black hole. It sucks A&P back into the past. And because it's so stressful, they cannot keep up the mental level, not the power of action, to stay oriented to the present, and they disappear in the past. And that's why we as clinicians say, look at me. He was there, the awful guy, and I'm here too. I wasn't there at the time. We start to make a differentiation so that thereby we help the patient to start to appreciate that as this stuff comes up, that it is actually not a current experience, but that it relates to something of the past. But as they do that, they say, it is so real. It is so painful. They sort of, as I said, get sucked into that existence. Thus, we must not only integrate, also differentiate. And the major differentiation in the presentification is the actual chronological present and the phenomenal present of the EP and the phenomenal present of the A&P. Can you track that?
Yeah, thank you.
Okay. You will know that from your therapies.
Yeah.
That when traumatic stuff comes up, that they get sort of sucked into that past. And when that happens, you get sensitization rather than, if you like, desensitization. Uda, you raised your hand.
My answer to your question was that my observation is that the EPs want to help. The longing from the EPs is to help A&P to realize that it happened to him or to her. I think that's a longing from the EPs I wrote.
Mm-hmm.
And so that the A&P has to physically feel it as if it is happening now, to realize that he has experienced that. And also, I think that the EP's longings is that the therapist realize that something happens awful to the person. So they bring up all the things. The longing that the A&P and the therapist will realize the cruel things.
Yes. Yeah. EP sort of at some level
Yes.
experiences, I cannot solve this problem on my own.
No.
I
need help.
I need an encounter. I need someone to share these feelings with me.
Yeah.
Without getting lost in those feelings.
No.
There should not be a symbiosis because that's not helpful. In a nightmare, you get a temporary symbiosis, if you like.
Yes.
And that's not helpful. Thus, A&P must keep her feet in the present, and at the same time experience the phenomenal realities of the EPF. Now, in this frame, it is not seldom that A&P perceives the fragile EP or the fragile EPs as exceptionally demanding. They want everything from me. I should take care of them all the time, etc. And actually, in most cases, that is not true. In as much as A&P takes a step in the direction of EPF, they are content, they're happy.
Yes.
Not totally happy, but they gain a little confidence that A&P can come their way after all. They are not over demanding in most cases, and it's a very important experience for A&P that holds.
Yes.
Because they think when this thing comes, this is only the first in a row of 1,000 things. And that will flood me. I can't go there. That's the idea.
And they get confidence each other, huh? Not confidence in other people, but here.
Yes.
And that's the thing, yes.
And that's why we set up those meeting places where the parts get to know one another, That's
Yeah.
why I say A&P, you can meet the EP, and EP, in the meeting, you first have to sort of get rid of the dark stuff and put it in a closet. You're only here and only in part. And it's only later and not seldom in steps that we start to integrate the trouble, some experiences. Thus, to overcome the phobia that A&P has for the EP and the traumatic memories, we generally take a gradual approach. When that graduality is not needed, you do it straight away. As for example, with EMDR or exposure therapy, as behavior therapists call it. Why? Because A&P has the longing and the capacity, the power of action to deal with it. But if it's way too much, and if there's not a therapeutic holding, and the holding is absolutely needed to have A&P and EP meet each other, then you need to set up relationships with the parts as a therapist. They need to gain some confidence in you. They need to gain some confidence in each other, as you say, Uta, quite correctly. And once that structure is there, that foundation is there, you can start to integrate the traumatic memories. Yeah. Any further questions? Remarks?
Yeah, may I speak?
Yes, sure.
Yes, concerning to the last point, I have a picture which works good for me. So I often see the EP as a child, and me as a therapist, the adult, and the A&P as an adult too. So one can say, or one could say, that two adult persons take care of the little one. So this is, for me, it's a picture that works well in this situation, that the A&P can learn how me as a therapist works with the little one.
Yes.
And it's kind of a family or something.
Yeah, I think basically that's a good model, Jens. As a sort of addition, I would like to remark, don't fall in love with your own pictures. They're helpful, they're your tools, your instruments, and they can really apply to the patient, but it may be different. For example, the EPF may be older, the A&P may be younger than you picture them to be. And therefore, I would suggest that you certainly show interest in the features of the A&P and the EPF. What is their phenomenal self and world like?
Yeah.
Instead of being too much guided by your own ideas. I'm reminded here of a somewhat funny example. I was with a couple of colleagues in training for hypnosis. And we were starting to work with metaphors and analogies. And then there was this guy in the group, and he was crazy about crystal glass. That was his wonderful hobby, and he could speak in a very engaged way about that. And as he was using a metaphor with the patient in a practice group, of course, he started to use the images of crystals. And he was enthusiastic. He was in his own trance, and the patient was totally bored. And he never noticed that there was no match, that his metaphor did not really sort of appeal to the patient. And that's why I say, don't fall in love with your own picture. Know that it's a strong image, a tool that is helpful to you. And what I'm saying is check with the patient if your perception, your picture fits
Yeah, sure.
the world of the patient.
Yeah.
But that said, yes, in many cases it will hold. And then it is a good idea if A&P as the adult have no clue how she should or could relate to EPF, in part because there was never any proper caretaking in her life. she has no model, then it can be helpful that we as therapists serve as the model. And then we should not stretch that too far so that we become the caretakers of the EPFs. In the end, it's a step towards A&P engaging with the EPF.
Yeah, sure.
And you know that.
Yeah.
Okay. Thus, you can set it up, but also as soon as possible, engage the A&P along with us. Let's tell the child together that. And once that works, A&P on their own can tell the little one that,
Yeah.
etc. But I guess you already knew that. Good.
Thanks.
You're very welcome. Any other thing?
I would like to ask you something. Would that be okay?
Yeah, sure, Dagmar.
You
Please
can
go
hear
ahead.
me. So I'm still struggling with the borderline personality differential diagnosis we had in the last hour when
Yes.
we are talking to Fabian. I'm just dropping this off because I think it's better this way. My impression is that I have many patients who I would consider borderline personality disorder or complex PTSD as differential diagnosis, but not borderline personality disorder and DID as a differential diagnosis. So I was kind of confused when you were talking about mixing up borderline and DID. And I had the impression that it's a who makes the diagnosis? Yeah, it's a kind of what is my attitude towards the patient if I say it's borderline or it's complex PTSD with maybe some dissociative symptoms like fainting, fainting spells, something like that. Because on the one hand, I have got the idea I've got to educate the patient to behave in a better way. And on the other hand, if I say, in my understanding, complex PTSD, I would have the intention to understand what's going on and to help the patient to make sense of his symptoms, her symptoms in most ways. Yeah. So am I completely wrong with not mixing up borderline and DID? Because that never occurred to me. My DID patients all were so clear DID and not borderline that was kind of irritating for me.
Okay. Well, I'm happy to hear that your DID cases were not borderline, because if you start this work, become engaged in this work, and you have a complex case of DID with many parts who are also borderline, that is, meet the criteria for borderline personality disorder, then treatment is 10 times more complex, if I may put it that way, somewhat loosely. Therapy is much more complicated because of the borderline features in all these parts. If only one or a few parts have borderline features, treatment will be, generally speaking, easier. Please know that DID can be combined with borderline personality disorder. If we look into research, it goes up to about 30–40% even, some studies suggest. Perhaps if we take a closer look, it may be that there is some confusion that because of the presence of controlling EPs, some DIDs are called borderline, whereas in my understanding, it would be a controlling EP. Thus, it may be worthwhile to make that distinction. Another remark I'd like to make is that don't make too much of a diagnosis. On the one hand, yes, a diagnosis is useful. It's scientifically useful. It is clinically, practically useful so that we have something to write in the reports, in the documents. Generally, we need a diagnosis, but let not take the diagnosis the place of good and active trauma therapy. And that is, as I would see it, meet the patient where she is, in whatever way of being or ways of being. And then only in the course of therapy decide is this a mode of longing and striving? Does it fit that idea, that concept? Or is it indeed really a dissociative part with its own first-person perspective? I would test the idea to what extent there is a part or a structure has its own phenomenal self or is sharing a phenomenal self with other modes as we create the paths in going. And it's over time that it becomes clearer.
Yeah.
It's not seldom that we start with a case where we think it's complex PTSD, where in the end it is DID. Why? Well, we couldn't see it. It was not in sight.
Yeah.
But what we can do is, of course, check the symptoms, the positive and the negative symptoms, somatoform, psychoform. We'll address them in the next video, but you know them already. That I find important.
Yeah.
What symptoms are there? Because the symptoms, in my understanding, are actions or substitute actions. Thus, what is the patient actually doing? What is the patient longing for? Those questions I find in the end more important than the diagnosis as such.
Yeah.
And if it becomes clear that what look like dissociative parts, agents, are actually strongly developed modes of longing and striving, all the better, because the work is more simple. If it works the other way around, you thought they fit the idea of a mode of longing and striving, rather strongly developed. In the end, it is a dissociative part. That also happens. Because I would like to say, yes, we make a sort of assessment, but we can, in each and every next therapeutic session, reassess and reassess. And that's what I call an active assessment. And therapeutically speaking, I find that in the end more important than the diagnosis as such, according to ICD-11 or DSM-5.
Yeah. Well, I fully agree, and I'm relieved because that's what I live with my patients, and making a diagnosis is always, well, for sharing it with others, but not, and for having something in mind on which level am I? Am I in moist air or am I in full rain, as you said before? Yeah, right. Just to have an idea about where I'm standing with the patient and where she is in her inner structure. But I have to find a way to talk to other people if I want to teach them or supervise them or talk to my colleagues in the clinic. So then I use these words, complex PTSD or DID, just to give them an imagination. But that's what you said right now is what I feel when working with them. Yeah, that it can be different every single meeting we have. Then something can pop up that changes my diagnosis.
Yes, yes. Generally speaking, I would also be careful. If you sort of suspect the ID, but if you have no proof for it, don't give the diagnosis.
No, never.
Therefore, slowly.
Yeah.
And in communication, I said, well, according to DSM-5, it looks like such and so. Mm-hmm. When I, however, speak about the patient, I'd like to tell you that what I find with her is that such and so is the case. That seems to be her trouble. I'd rather give a dynamic assessment than a static diagnostic label. Yeah. So when I say complex PTSD, what I mean by that for this patient is such and so.
Yeah.
Yeah.
Thank you. Great.
You're very welcome. I think we can call it a night. Any urgent matter? No questions. No questions, Kirande. We can.
I have a small question for Ingrid. So can you stay on the after the meeting? Everyone is said bye. Good.
Okay.
Thank you. So I wish everyone a pleasant Saturday evening, and I hope you can relax tomorrow.
Okay. Good.